So one such thing is the use of transcranial Doppler. It is, as we discussed, portable, non-invasive method to measure the cerebral velocity. So what is the concept here is, we have a phased array in our ultrasound machine, and we then install the software for measuring the transcranial Doppler measurements and measuring the cerebral velocities, and using the peaks in our cranium like the transorbital, transcranial, transtemporal as well as your submandibular windows, we try to measure the peak systolic velocity and the end diastolic velocity in the major vessels like middle cerebral artery, anterior cerebral artery, vertebral arteries and the basilar arteries. In addition to that, we also look for your mean cerebral velocities in our carotid arteries. So based on that, the waveform, we get a peak systolic velocity and the end diastolic velocity, and then we calculate our mean flow velocity. It has been postulated that this mean flow velocity should be at least less than 120 centimeters per second. So if it is less than 120 centimeters per second, then you are very clear that there is no cerebral vasospasm which is occurring. And if the mean flow velocity is between 120 to 200 centimeters, you can suspect some amount of mild to moderate vasospasm. But a mean flow velocity of more than 200 centimeters is definitely graded as a severe vasospasm. Okay, so this is your transcranial Doppler waveform, wherein you can see the upper peak which is called as the peak systolic velocity and the lower peak which is called as your end diastolic velocity. Okay. These values are mostly done in terms of your middle cerebral artery or the major artery, which is very easy to do it. And so based on these values, you calculate your mean flow velocity, which is nothing but your end diastolic velocity plus 1/3 of your PSV minus EDV. Just it is similar to calculating like your map. Okay. And based on this, you get your mean flow velocity. And we saw that it should be less than 120 centimeters per second. So this transcranial Doppler is utilized for your middle cerebral artery, anterior cerebral artery, posterior cerebral artery as well as basilar cerebral artery. And this transcranial Doppler is being utilized for the middle cerebral artery, anterior cerebral artery, posterior cerebral artery as well as the basilar artery. The sensitivity and specificity of it is actually highest for the middle cerebral artery. That is why we have a standard of 120 centimeters per second. As we can see, the sensitivity and specificity for MC are around 80%, whereas as we go down from anterior cerebral or posterior cerebral, the sensitivity and specificity decreases. And for the basilar artery, it is around 75%. So this is a non-invasive, but definitely it is exposed to your subjective error. It depends from your subjective variation from person to person on how he is able to diagnose and calculate the peak, as well as the availability of this transcranial Doppler is not very easy. One more thing is the problem is here is the mean flow velocity can be higher even in terms when there is a hyperemia in your blood vessel. So to encounter this false positivity, there came to be a ratio called as Linegaard's ratio. So as we saw in previous slides, this Linegaard ratio is nothing but the mean flow velocity in your middle cerebral artery divided by the same side mean flow velocity of your internal carotid artery, that is the extracranial part of your internal carotid artery. So it was postulated that this Linegaard ratio should be at least more than 3 for you to diagnose cerebral vasospasm. If the Linegaard ratio is less than 3, then you can term the increase in your mean flow velocities secondary to your hyperemia. So that is what they are comparing. They are comparing the velocities of your cerebral artery MCA, which is damaged, to the velocity of your the same side carotid artery. So if there is an increase in that, your MCA, obviously your Linegaard's ratio is more than 3. So if the more than 3, then it is diagnosed as your vasospasm. But if it is 3 or less than 3, then the mild increase in your mean flow velocities in your MCA is secondary to your hyperemia. So here we can see the probe is placed at transorbital, transtemporal and as well as your submandibular level. And then this is the peak systolic velocity and this is your end diastolic velocity, and based on these we calculate our mean flow velocities.